We continue our discussion on coronary artery disease, and now we'll talk about management of acute coronary syndrome. So before I discuss in great detail, let me give you a summary of how we are going to manage a case of acute coronary syndrome. So we have a management, two issues. One is the management of ST elevated MI, and other is non-ST elevated MI. In both the cases in acute coronary syndrome, we give aspirin and ticagrelor. They are antiplatelet drugs. We give Betablocker, we give statin, ACI, morphine, nitrates. This is given in both. And of course, we also plan for PTCA in both the condition. Heparin also we try to give in both the cases because we want to prevent deep vein thrombosis. The only major difference is in acute ST elevated MI, we can do thrombolysis, and thrombolysis is not done in non-ST elevated MI. Otherwise, management of all the three elements of acute coronary syndrome, that is ST elevated MI, non-ST elevated MI, and unstable angina, this treatment remains same. So now we talk each one of them. First of all is antiplatelet drug. It's one of the most important thing that we talk about, and we use double antiplatelet therapy. Okay, so what we write as DPAT, and they reduce the rate of mortality also. Okay, and overall mortality also. So we use aspirin, and we also use any one of the three, clopidogrel, prasugrel, or ticagrelor. They all three are P2Y12 antagonist, receptor antagonist. We can use any one of them in combination with aspirin. Okay. Now regarding aspirin in particular, it has got a very huge mortality benefit, as I was talking to you. Now, if you use aspirin in early intervention, it reduces mortality by 30%. So that's why aspirin should be given as early as possible, soon after myocardial infarction. Then after that, we go for glyceryl trinitrate. This is one drug which has got analgesic effect, especially for pain. And one thing very interestingly, how does the drug act? Of course, it has got dual action. Most important, rather more important, is it dilates the peripheral venules. Thereby, the whole blood is pulled into peripheral tissue, so it reduces preload. Once the preload is reduced, this reduces wall tension. Myocardial wall tension is reduced, and that's how it really helps in angina. And other method is it is a coronary vasodilator also, and this occurs due to nitric oxide release. So it has got double action of, and remember, this is to have it for pain abortion. Okay, it's abortive for the pain chest, to be more precise. Of course, in case of acute MI, when the pain is very severe, we may use morphine. Morphine we use IV 2 to 3 milligram, or we can use IM also, but the dose is 10 to 15 milligram intramuscular. But it has got only symptomatic relief. It doesn't have a mortality benefit. Now, beta blocker, that's one of the mainstay of treatment, and usually we use metoprolol. And how it going to help us? It's going to reduce the heart rate. As the heart rate is reduced, it reduces oxygen demand. So in all case of CAD, maybe even angina also, we always give beta blocker unless there is some contraindications there, then we do not give. Okay, then ACEI. What is the role of ACEI? It's a very important role to play. They control the blood pressure because they are potent. They reduce the peripheral resistance. They dilate the arterioles, and thereby they reduce the peripheral resistance. BP is controlled. It also helps in the treatment of LVF, because it's a potent vasodilator, so it will going to treat a case of LVF also. But one more advantage in acute MI, it helps in infarct remodeling. This way, it makes the scar tissue very firm. So in that way, it prevents rupture of the myocardium. We also use low molecular weight heparin. It is mainly as a preventive drug for deep vein thrombosis. Otherwise, it can lead to pulmonary embolism, which can add to the problem of myocardial infarction. GP2B3A receptor antagonists. They are the drug like epsiximab, eptafibatide, they are GP2B3A receptor antagonists. They are antiplatelet drug. Most widely used drug in actual practice is epsiximab. It is given by IV infusion, and it is especially useful in following situation: patient having persistent or recurrent ischemia, non-ST elevated MI, patient having diabetes with acute coronary syndrome, angioplasty and stenting. This has one of the most important and one of the most definite indication of using GP2B3A receptor blocking drug. They really prevent the stent-induced clot formation. Statin are added in all cases of acute coronary syndrome to look after into raise LDL level, because if you do not control raise LDL, it's going to produce more atherosclerosis and it can lead to recurrent ischemia or recurrent infarction. So controlling LDL is a must for any treatment of acute coronary syndrome. Now we talk about revascularization. But before I discuss what is revascularization, we should know some basic concept of myocardium salvage and concept of reperfusion therapy. What is this basic concept? And if you understand this thing very clearly, your concept about management of coronary artery disease will really sharpen to a great extent. So for that, let's learn the basic concept. Basic concept, this is the coronary artery, and this is the myocardium, and here is the plaque. And if you recall my first lecture on coronary artery disease, how we diagnose the case of angina. Angina we diagnose by history. History of what? Pain chest on exertional pain chest is the classical point in the diagnosis of angina. Exertional pain chest. What happened and why it happened? Let's learn the basic. Heart rate is 72, blood is coming, and demand and supply is all right. There's no problem. Now when the patient start walking, as the patient start walking, heart rate will increase 80, 90, 100, 110. Let's say heart rate has gone to 126, from 72 to 126. More the heart rate, more is oxygen demand. But now fixed obstruction is there. Demand is more, supply is less. Now patient have pain chest due to tissue ischemia. It is squeezing type of pain, what we call as Levine sign. Now patient will stop. Heart rate will again come back to 72. Demand supply is there, the pain disappear. So now we understood why in case of angina, patient develop pain chest on exertion and why the pain disappear on rest. Well, this is the case where the patient has recurrent ischemia occurs, recurrent pain chest, but it's a stable angina. And it is a predictable case. What do you mean by predictable? Patient says, when I walk for 1 kilometer, then I have pain chest. He can predict that it's 1 kilometer is the area. Because by the time patient heart rate has gone to the level where patient has tissue ischemia. Stable angina is the main problem. Okay. Well, when this recurrent attack occurs, patient tend to develop additional collateral into the chronic ischemic area. So we call this myocardium as a hibernating myocardium. Hibernating myocardium are those areas of myocardium which gets recurrent attack of ischemia because of the blockage in the concerned artery. Now, one day a clot comes, or maybe a rupture of the plaque occurs and thrombus formation occur, or maybe a embolism comes and that blocks the complete artery. And now what we call as acute coronary syndrome or acute MI. Now the total blood supply is gone. We say patient has developed acute MI. So this is the normal ECG. And when this acute pain occurs, now tall T wave occurs. Tall T wave. It's the earliest finding to happen in the case of acute MI. And it occurs within minutes of acute MI. Now, there is no blood supply into this segment of myocardium. Tissue ischemia is there, but tissue is viable. Now, what happened mechanically? Normal, this is the way myocardium is contracting. Now, as the blood supply is total stop, there is no contraction in the myocardium, we call as akinesia, or there may be slight movement, we call as hypokinesia. So, patient can develop akinesia, okay, this is the problem, what is happening, what we are getting mechanically, right? Well, for next 2-3 hours, this tissue is still surviving. 2-3 hours, how do we know? In the ECG, we start getting ST segment elevation. ST segment elevation, here a tall T wave was there. But remember, still, pathological tissue ischemia is there. If we can open up the block within 2-3 hours, we can reperfuse the myocardium and we can save the entire myocardium. I can give you a better example. The better example is, suppose there is one building of 100 rooms and there is a fire start in the veranda. And the fire brigade come within 2-3 hours and they control the fire and all the 100 rooms are saved. Suppose the fire brigade come after 6 hours. By the time 5 rooms are burned, what fire brigade will do? Rooms burnt are burned, nothing can be done. But now the fire brigade will save rest 95 rooms. Suppose the fire brigade come after 10 hours, 40 gone, 60 saved. Fire brigade come after 18 hours, 90 gone, 10 saved. Fire brigade come after 26 hours. Now everything gone, nothing is saved. What inference we are drawing? Not only fire brigade arrival is important, its timely arrival is also very important. And number 2, the purpose of fire brigade is to save the rest of the room. Rooms gone are gone, nothing can be done. Exactly same thing happening here also. If we can open up the block within 2-3 hours, we can save the entire myocardium salvage. Okay, but if we are not able to open, then after 2-3-4 hours, tissue necrosis start. What type of necrosis? It is coagulative necrosis. It starts from center to periphery, and now tissue is dead. That means rooms are burned, nothing can be done. So that's why we should reperfuse the myocardium as early as possible. So this is the reperfusion therapy. I hope you have. So now how we can reperfuse the myocardium? So we move further. In reperfusion myocardium, hibernating myocardium, you understood? Okay. Now, one more thing I like to add. Rather, first, this is the hibernating myocardium, chronically ischemia patient. This narrowing is there. This tissue is getting chronically ischemic. And if you reperfuse the myocardium by opening the blockage, how we are going to open the block, I will discuss soon, and again I will come back to this slide of stunned myocardium. What is this? This you will understand once you understand the concept of reperfusion. So how we can reperfuse the myocardium? First way is to reperfuse is thrombolysis. There are certain contraindication, major bleeding, anything, it may be CVA or any other major bleeding is there. We never thrombolize. Patient has been recently done, some major surgery has undergone, then again we do not reperfuse, especially in the last 2 weeks. In the last 2 weeks. And we talk about major bleeding is maybe in the bowel, maybe upper GI bleed, or maybe in the brain. They are the major bleeding where we will not use. Severe hypertension, if BP is above 180 by 110, we will not thrombolize. And maybe non-hemorrhagic stroke in the last 3 months, we will not do thrombolysis. Okay. The second way of reperfusion is PTCA. Now, if both the facilities are there, PTCA is definitely better than thrombolysis. Thrombolysis is done in those centers where there is no facility for PTCA. Now, PTCA is superior to thrombolysis because of following reason: better survival, fewer complication, less likely to develop complication of MI also, and it reduces mortality also. Okay. Now, there are certain complications of PTCA also. Nothing is foolproof. Sometimes it can lead to rupture of coronary artery. Suppose coronary artery size is too low, or the person who is doing PTCA is not careful, he may exert more pressure, it can rupture the coronary artery. Restenosis is a major problem, and hematoma is a big problem sometimes. Now, rates of restenosis. Well, those we use different type of stents we use. If no stenting, if you are not using any stent, then chance of restenosis are 30 to 40%. If you are using bare metal stent, chance of restenosis are 15 to 30%. If you are using drug eluting stent, then it is less than 10%. That's why it is always drug eluting stent is the first choice. But the bare metal are we use where the cost factor is the main consideration, but they are much more expensive as compared to bare metal. So not in every part of the world patient can bear the cost. Depending on the cost, we can use bare metal or drug eluting, but definitely it is much better. So now when you are talking about drug eluting stent, in fact, why bare metal stent tend to have more stenosis? Because they induce thrombus formation. Because stents themselves are a metallic particle. Okay, so that's why we are using drug-coated stent. Now, what drug we use to prevent clot? Paclitaxel and sirolimus are the drug that we use are in drug-eluting stents. So here's a beautiful picture of telling you this: the plaque is there, here's the catheter, and here this expanded stent is there, and now stent is left here, and catheter is taken out, and this expanded stent has compressed the plaque. Now, CABG. What are indications of doing CABG? We do in left main stem disease, triple vessel disease, especially involving LAD. If we are not able to perform PTCA, this happens when artery involved is diffusely involved artery, or it's a massive calcification is there. In calcified plaque, you cannot do PTCA. Or depressed ventricular function is maybe LV ejection fraction is too low, then we can think of doing bypass surgery. Now, we also do bypass surgery to relieve symptom. That means we have patient of angina not responding to drug. We have unstable angina. If angioplasty is unsuccessful, in such cases we can think of doing coronary artery bypass. Which artery we use? We use internal mammary artery. Left is better. Left internal mammary artery, right internal mammary artery, radial artery, and we also use venous graft in the form of long saphenous vein. Left internal mammary artery is much better. And if CABG and PTCA both are clinically valid, PTCA is definitely preferred. That means, if I have to summarize the thing, if you have three ways of reperfusion: thrombolysis, PTCA, and coronary artery bypass surgery, this is the best out of the three for reperfusion of the myocardium. Now, it's a beautiful picture for the meaning of bypass surgery. You can see this bypass graft is there, a venous graft is there, Let me explain to you what is there. This is the aorta, this is the coronary artery, and here the blockage is there. Now they take a graft, maybe from internal memory artery or the long saphenous vein, they will unite like this. So now blood will go. So this same thing is shown in this picture also. Mortality in acute MI. Around 25% people do not reach hospital. They die on the way or at home. Under 25% they die in the hospital. That means mortality is as high as 50% in acute MI. But remember, this percentage varies from place to place, city to city, country to country, and which center patient has gone, whether it's a fully equipped cardiac center or is it just an ordinary hospital, because not every part of the world has well-equipped ICU. So, but I give you a general idea that it carries a very high mortality within the first 24 hours. Now, mortality benefit in acute coronary syndrome, they occur with the following drug. Aspirin has definitely, if you use aspirin in early intervention, you can reduce mortality by 30%. Similarly, beta blocker have a good mortality benefit. ACI and statin also have a mortality benefit. Means when we use this drug in acute coronary syndrome, mortality is definitely reduced. But remember, drug like morphine and nitrate, they don't have mortality benefit. They simply are helpful in relieving symptom. So now again, little bit of pathology to explain you better. This is blood flow. Now plaque is there, and now this disruption of plaque is there. Okay, and that can block the artery in such a way. Complete blockage is NST-MI, complete blockage. Partial blockage is non-ST elevated MI. Now, once we reperfuse the myocardium, that means we have opened the block and we have made the artery flow. This we have removed the blockage and blood is going. Once we start reperfusion, remember, although blood has entered the myocardial tissue which was ischemic, but still for a long time, maybe a day or two or three, myocardium doesn't have a proper mechanical contraction. Remember, tissue has been reperfused, maybe by thrombolysis, maybe by PTCA. Blood has come, but still myocardium is not contracting proper mechanically, there is no contraction. The reason being, although blood supply has come, but at the tissue level, at the level of mitochondria, proper metabolism is not going on. And that's why this is what we call a stunned myocardium. So stunned myocardium is a post-perfusion myocardium, and hibernating myocardium is a pre-perfusion myocardium. And no need to say that revascularization is maximum benefit for hibernating myocardium. So now ECG finding, what we get in non-ST elevated MI, we may get ST segment depression or maybe T wave inversion. And again, this is normal acute unstable angina, T inversion, ST depression. And remember, after a week later on, STT come to normal and new Q wave. There's no Q wave in non-ST elevated MI, but Q wave is the only finding that is there in old MI, ST elevated MI. Okay, so say other ECG for better understanding, T wave inversion in unstable angina and ST segment depression in unstable angina. Now, one more thing, in unstable angina, cardiac enzymes are not raised, and in ST elevated MI, cardiac enzymes are raised. Okay, but line of management remains the same in all the three. The only exception is that in non-ST elevated MI or in unstable angina, we do not use thrombolysis, the point I discussed, but I reinforce my statement so that better understanding of subject. So now a quick recap of the last minute revision point about management of acute coronary syndrome. We use antiplatelet drug double antiplatelet drug. We use nitrate for pain, abortion of the pain. Analgesia, we use morphine. Beta blocker to control heart rate. ACEI to control BP, to treat CHF and for infarct remodeling. And low molecular weight heparin, especially to prevent deep vein thrombosis and to prevent pulmonary embolism. GP2B3A antagonists, again antiplatelet drug, especially useful after stent. Statin to control lipid levels. Myocardium salvage, I discussed. Thrombolysis, PTCA, CABG are the three ways we can do myocardium salvage. And in unstable angina and non-ST elevated MI, we do not use thrombolysis. Thank you very much for watching this video.